Good afternoon. Thank you for attending part 2 of Pearls I Wish I Knew. Today, it's going to be Charles, Darren Nygren, and myself. You're in good hands. There's a lot to learn today. We had some questions and topics practitioners requested we address, and we are going to touch upon them and ask you to provide tips, recommendations, questions. You can do that through the chat box, which is located on the control panel. We have been really enjoying the pictures of all the participants while they are watching the webinar, so please send those pictures in. We are going to feature quite a few of you on the EyeSpace Facebook page as soon as the series is over with. So join me in welcoming Charles and Darren Nygren.
Thanks, Angela.
Thank you, Angela. Today, we're going to continue our talk on Pearls I Wish I Knew. So we started this topic last week and we got into it and we ran way over time. So we took some of those questions and comments and thought it would be a great idea to continue today. So the first on our list that we're going to look at is long-term follow-ups. So the question was, what do we do long-term? So let's talk year 1 and year 2. So long-term follow-ups you didn't call. So what we were talking about is what happens when you've completed your Ortho-K fit, everything has gone to plan, you've reached your target power, and the patient goes home. When do you see the patient again? What do we do with those follow-ups? And what do we charge for those follow-ups? Now, these are all good questions and they can warrant a lot of discussing. So maybe let's just talk on the highlight points, Darren. So for me, on a clinical level, there's a couple of steps we need to follow. If you're doing myopia management and you are concerned about looking at the axial growth length, when do you follow up these patients? So for me, if we do talking myopia management, you want to make sure that whatever treatment modality you're following, I think the first follow-up should be around about the 6-month mark. And that would be a great time to look at axial length measurements and so forth and make sure whatever protocol you have in place is effective, or if you need to do any modifications to your treatment plan. If myopia management's not that big on the radar and we're rather just talking about myopia control, normal Ortho-K fitting, for me, that first follow-up should happen about at year 1. And on year 1, there's a couple of things that you want to look at. First of all, on a clinical level, we want to make sure the eye is healthy. We want to make sure the Ortho-K process is still effective and that we are managing the patient's expectations. So on that first year follow-up, you will do a normal routine eye check. For me, you want to go look at the cornea. You want to make sure it's healthy. There should be no staining. There should be no other pathology present. You want to do what we call residual refraction. So you want to make sure that your target power is still reached, that you've cancelled out any of the myopia or hyperopia that's still present. Now, on your day of dispense or when you've completed your lens, I want to remind you that on the last talk we said on that day, it's important to do a refraction over the lens. We want to make sure that with the lens on eye, that you are correcting all the prescription. And that's also giving us a baseline for doing future checkups. So if your patient arrives on year 1 and the fit was successful, and there is a residual prescription. In other words, when your patient left your practice last year, they had a 0 prescription or all the target power was reached. Now they come in year 1 and there's a residual prescription. There's a -1. The next question that should come up in your mind is that prescription, the residual prescription that's now present, that -1, is it due to the fact that the lens is not functioning, doing its job like it should, or did myopia progression occur? Did the eye become more myopic? And the easiest way to check this is to perform another refraction over lens. In other words, you put the lens on the eye and you do a refraction. Now, if that refraction over the lens is still what it was last year, in other words, you're still getting that near zero over refraction, then we know that -1 is due to the lens not doing its job. In other words, there's something happening to the lens or an environment the lens is in that's not reaching its target power. If you get a prescription over the lens that wasn't there prior, in other words, your residual prescription is -1 and the refraction over the lens is -1, then we know that's not the lens that's not doing the work. It has more to do with myopia progression, and that would be a great time then to change the design of the lens. You can still use the previous year's map, just add your refraction over lens to the prescription of the old lens that you used, and that should give you new target power to go ahead. So things that can cause the lens not to work properly are numerous, but most commonly it will be something on the lens. In other words, there's either protein on the lens is warped, the lens is damaged, it's cracked, the patient switched the lens. There's something to that lens that either needs to be corrected, fixed, deprotonized, clean, polished, or replaced if the lens is warped or broken. The other things to consider is my patient following protocol? Are they wearing the lenses? Did they swap the lenses around? With EyeSpace, that's pretty easy to see because you can just check the colors, and if you have a serial number, you can check the serial numbers. But you want to go and make sure that whatever is happening is it due to the lens not performing, or is it due to pilot error, to the patient not doing what they should be doing? For me, on any follow-up for Ortho-K, topography is an essential because topography tells you what the lens is doing on the eye, and that gives you further information. So for me, that would be the basics, at least, of doing a follow-up. So follow-up in Ortho-K for me is a full exam. There's a number of things that we need to go through and to check. And then, Darren, you're welcome to step in now, but that also warrants billing. So I'm always a proponent for you must bill for the work that you do. So if you do all these extra work, or extra procedures, then obviously you need to bill accordingly. So what are your take on that?
I agree that it's you need to be paid for what you provide, pay per service. And so there are just some practitioners like to have a set fee, and I find that oftentimes that'll include a replacement pair of lenses, and so you bundle it together. Well, either one, it's just whatever works for your practice.
And that will be on a yearly basis, or do you see that practitioners will replace every second year?
The majority in the U.S. are doing it on an annual basis, and then so the price would include topography, a new pair of lenses, and the examination.
Yeah, and Kenneth, thank you for that comment. So on that follow-up visit, you definitely want to examine the lens itself. You want to make sure that the lens parameters are still according to spec. So basic stuff like checking the back optic zone radius, again, making sure the lens is worn in the right eye. You can examine the lens under the biomicroscope and check for any damage or protein deposits. What I commonly see is a lot of deposits happening in the reverse curve area. And so depending on your patient's cleaning regime, that might be a good time for a deprotonizing process. You can do your progens. If there's excessive protein buildup and it's not on the cards to replace the lens, this is even a good time to send that lens away to your lab to get the lab cleaned and polished, or if you have any facilities at work that you can use to clean and polish the lens, that's a good time to visit those services as well. Do you find that people send lenses in, Darren?
It's rare, and in the scenario that we described where they come in for year number 2, say, then they get a new set of lenses with changes if indicated. We do a deep clean on their previous pair, and that becomes the backup set. Practitioners, I think, have gotten away from doing in-office polishes because of the possibility of altering the parameters with that reverse curve. And I agree with that if you're going to have them polished, to send it to the lab for that scenario.
Yeah, and that's a valid point. One of the things I've also seen happen on occasion is people were doing well, and then come hay fever season, you see a bit of residual prescription coming through. So I've definitely seen on a clinical level that stuff like GPC can have an influence on the overall reshaping. So, one of the things you got to check when that patient comes in is just look underneath the lids and make sure you don't sit with some form of allergic response. And again, that can be either from the environment or from protein buildup on the lens as well. So you want to manage stuff like that as well. So be careful of your hay fever patients, especially during the peak season of hay fever. You can see certain reduction in the myopia reshape if there's severe GPC present. So that was one of the other things that I've seen in practice.
And the symptoms, it's funny you mentioned that, because the symptoms, allergy related, really flare up. So I can tell what season it is because people start calling. Right now we're in our spring, and I've already polished 2 sets of lenses today for customers that have come in. And then in the fall when we start using our heaters. And so those 2 times, the combination of the AC and allergies, and then the heat in the fall.
Yeah. And also on the follow-up, for me, it's always a good time just to go through the checklist with the patient. So they've had a year on the lenses now, and they tend to start straying away from the recommendations that you've given. So this is a good time just to recheck what cleaning solutions they are using. Are they still following the cleaning protocols like you've set it out? A good time also here is just to revisit insertion removal techniques. So if it's required for the patient to put the lens in, so from our previous talks, I like it for the patient to come in without their lenses on the eye for any of their follow-ups, but I do want them to bring the lenses along. So at one point, you maybe want to put that lens back in the eye. And this is a good opportunity, if this is your first year follow-up, for the patient to do it. So I will ask the patient if they don't mind putting the Ortho-K lenses into their own eyes. And I just observe the process that they follow. And sometimes you pick up some bad habits, and this is a great time just to correct those bad habits of insertion removal of these lenses. You can, at the same process, look at their cases, make sure the cases are clean. Are they aware of the hygiene component? Are they following those protocols? What I've often found is they tend to stray away from your cleaning suggestions as well as the cleaning solutions. It might be that you recommend product A, but 6 months ago they went to a dinner party and somebody across the table, they got talking about their eyes, and somebody said, there's this special at this store or pharmacy, and that solution is a lot cheaper. Why don't you use this? And they will definitely, some people will then consider that as a bargain and then switch over the protocols. So this is a good time just to revisit, are they using something like, I'm quite a proponent of peroxide cleaners. Are they still using the peroxide cleaner I suggested, or have they swapped to something else that's, and in some cases, not even appropriate? Stuff like rinsing the lens under the tap comes to mind here. I've seen some patients do that. You find people wetting the lens, with saliva. So again, this is a great learning opportunity just to correct stuff like that. So I kind of always observe what the patient's doing with the lenses, and I'm trying to pick up any bad habits, or we'll have a discussion, especially if it's kids, if the parents come along, how's it going? Is Susie doing what she's doing? Are there any issues? And sometimes the parents are under the impression their child's wearing the lenses every night, but then the child comes forward and says, nah, I don't wear it on Saturdays. Or what's happened to me is I was looking after a child with divorced parents. So the mum was always coming in with the follow-ups, and she was very pedantic that everything should be done like it should be done. But then it came out after a discussion with the child, when the child visits the dad, the Ortho-K lenses are not worn. And there are many reasons for why that happened. So these are all practical things to go through. It's just do the follow-ups, talk to the patients, make sure there's no bad habits, make sure the cleaning is done over and above all the other clinical components that we need to do. If the lens is working and there's no reason to clean or replace and the lens is doing its job, then, again, from certain areas, that's quite acceptable and the patient will go away and we'll see them the next year. So when it comes to replacement of lenses, I feel this is an important thing to talk to the patient on day one. So yes, this is what Ortho-K is about. This is the fee for it. But keep in mind, like any eyewear, there are follow-ups. When you get your braces, you pay a certain amount, but for any follow-up visits, for any readjustment of your braces, there are fees involved for that. It's the same with Ortho-K. You've got your initial setup fees, your basic fitting fees, but there are follow-up fees that you're going to have to pay every year, 2 years, as you go along. And this is something the patient needs to be aware of, that there's ongoing costs of doing Ortho-K. And again, this is a good time to bring this up is when you start Ortho-K, not a year or two down the line. Now suddenly you throw all these fees at them. And this is sometimes the reason why people will start shopping around. So it's important to kind of lock these things into place long before you get to that point. From contracts and medical payments, Darren, is there anything else you want to add here?
No, I think just to reiterate that it's so critical to have a contract that you're comfortable with and that your staff is comfortable presenting to the patient as well, and make sure that the patient agrees to that contract and fully understands it. And then moving forward, it makes it so much easier.
Yeah, and then the last thing I just want to add for follow-ups, for the guys fitting EyeSpace, if you go on to EyeSpace online and you drill down to the specific order, right at the bottom of that order, there is an Ortho-K troubleshoot form. And if you open that form, it gives you a really good guideline of all the clinical aspects that you should be collecting when you do any follow-ups. So if you want to go there, the easiest way to do this now, Darren, is to go to the EyeSpace lenses.com website. You'll find the knowledge bases over there. And on the knowledge base, there's an article that says track and trace. Now, if you follow through that article on the track and trace, you'll get right to the bottom where we talk about that troubleshooting form. So you can either fill in that form or the progress form that's next to it, or just use it as a guideline. So if you go to number 3 there, track and trace, and if you go right down to the bottom, Darren, you can scroll down. So that's a full comprehensive description on EyeSpace online, what all information is available. And if you go right down to the bottom, you'll see there's a section that talks about the Ortho-K troubleshooting form. So it's quite a lengthy article, but if you scroll down, there we go. So that is a form that's available online that you can fill in, and that gives you a guideline of the kind of information we need, for instance, when you do a troubleshoot. So if you go up to the top section, for us, it's important to know, obviously, which eye we're dealing with, how many nights are worn, because some people tend to want to change lenses too quickly initially. If this is more long-term follow-up, then you're going to put in a year or whatever. We want to know the unaided visual acuity, both for distance and near, and that's for each eye. Obviously, the refraction over the lens is key. We find people don't pay enough attention to that refraction over the lens, but for me, that's key for follow-up, because that tells you where the change in the eye is occurring or where the change in the Ortho-K process is happening. The residual refraction, the script without the lens, then your treatment zone positioning. That tells you, in my mind, with the sizing of the lens, if that's correct. Did you get your target powers and so forth? You can look at edging and staining. So you don't need to follow exactly all those parameters on your follow-ups. You can add a lot more, obviously, but for us, that we feel that's a bare minimum of information we require on any Ortho-K checkup to make sure that the lens is performing to, the specs that we want it to perform. So on follow-ups, I think if we can summarize, at the very least, you should be following up once a year. Lens replacement will be based on arrangement with the patient, environment. I know in the US, the replacements will happen yearly. In other areas, that might be only 2 years. In some areas, people will even carry on wearing the lens longer. As long as you follow up and make sure that lens is not doing damage to the lens, to the eye, that's key. For me, it's always make sure the Ortho-K lens is not causing any damage, make sure the patient's comfortable with the lens, and then obviously that the lens is doing its job, that it's performing the way it should be performing. Billing, you'll have to look at your region and area, but for me, you are allowed to bill for the work that you do. So if there's a service that you provide, if there's in your follow-up certain stuff like topography, dry eye assessment, whatever you do, that entitles you to bill for that. And as you get more experience with Ortho-K, then obviously you know what's going to happen there. If the lens needs replacement, then obviously there's going to be chair time involved. You're going to do a follow-up on that lens. And so you have to be aware of the costing involved for that as well and have that discussion with the patient. In my experience, patients, once they know what things cost and they've agreed to it, they'll be happy to follow it. They don't like surprises. At that stage, if you just start piling on fees and they weren't aware of this, that becomes the hard sell, because now they might think, oh, he's just trying to make money off me, or she's trying to make money. Whereas if this was discussed prior, then they know this is coming, they've budgeted for it, they've steeled themselves for this bill that's going to come, and they should be more acceptable to it. All right, so if we then move along to the second subject, you have myopia.
Charles, do you prefer having an over-refraction with the phoropter or loose lenses?
I'm a big fan of trial lenses for many reasons, but primarily because the practice dealt with specialty lenses. And for me, it just became part and parcel that I'm getting better information from using trial lenses. With a Phoropter, with Ortho-K on follow-ups, for me, ret's quite important as well. And you have to polish up on your ret skills to also see what's happening there in the center. I don't think it probably matters too much, and there might be different opinions on this if you use the Phoropter on a follow-up. But I've always just been a fan of trial frames, and I basically never used a Phoropter in my practice. I always used trial frames, but that was a personal choice for me, and people will have different opinions. But if you're doing high powers, if you're doing keratoconus, stuff like that, I will always recommend finishing the refraction with a trial frame. You just get so much more information, and especially in the high powers, it allows you to measure vertex distances more accurately. And so if you're going to do something like the bespoke lens on a -20, that vertex distance will play a major role. So in cases like that, I'll definitely end up with a trial frame refraction.
And one other point along that line, Charles, is I would discourage the use of autorefractors in your Ortho-K patients.
Oh, absolutely. Absolutely. Yeah. Again, I'm a bit old school there, but I'm not a big fan of autorefractors when it comes to specialty lenses, just purely because the corneas you're dealing with are not normal prolate corneas. There's going to be something, call it wrong or changed with them away from the normal cornea. And autorefractors, in my opinion, are not geared to deal with the irregular cornea. It's not their skill set. So at the very least, it might give you a starting point or give you some information, but I will never base any decision-making solely on information I get from an autorefractor. For me, that's just a starting point.
As many as the U.S. EyeSpace accounts will attest, it's my lifelong mission to make sure every optometrist picks up their retinoscope on a daily basis when they're in clinic.
Again, we haven't talked about this, but we're on the same page there. For me, ret is essential, and you have to ret each and every patient coming in. There's just so much more information coming off a retinoscope than you can get from anywhere else, not just the prescription, but there's so many other clues that you can get from the red. So
Decenter
fully
treatment
agree.
zone. Yep.
Yep. All right. So the next step is, the question came up is how do you sell Ortho-K to the parents? And there's many approaches to this. So the approach I'm going to talk about next is kind of the guidelines that I followed in practice, and you might use it verbatimly, or you might take something or completely disagree. But when it comes to myopia, and especially dealing with kids and parents, you know, we've grown up with myopia as optometrists. For us, myopia is a daily, you know, part of our life. It's part of our vernacular. We think and sleep and eat prescriptions. But we sometimes forget that for parents with kids, this is something new, you know, and so for them to come in and have an eye check, and if there's no history of any prescription in the eye, there's normally a journey for that child before they arrive in your practice. You know, the teacher might have picked it up, an aunt or an uncle might have said something, or the mum noticed that the child's behaving abnormally. The child might have been, you know, complaining about difficulties at school. So there's a major concern for a lot of parents when the child comes into the practice. And none of us want to hear that there's something wrong with your child. It's the biggest fear of any parent is, my child has something wrong with them. So if the child's there in the chair and yes, there's signs of myopia, or you know, there's definitely myopia, you know, you look up the parent and says, yes, there is something wrong with your child. That's what the parent hears. You say, oh, your child's got myopia, and you go, you know, that's a normal daily thing. It's like drinking coffee. What the parent's hearing is, my child's going to die. My child's going to go blind. There's something wrong with my child. And I can see some people laughing, but, you know, that's what goes through parents' minds. So for me, it's always been a question of breaking it in portions and breaking it slowly. So what I like to do is throw some theory at the parents and give them an overview of what myopia is, what they can expect from their child. Because, you know, you get overbearing fathers, their child must be a sports star, and you've just broken that dream. You know, he wants to become a, you know, Air Force pilot. You've just broken that dream. You know, no father wants to hear his child's going to have to wear glasses on the sports field. So you got to manage both the parent set and child set. So Darren, if you want to move along to that first or the next slide on the deck. So this is kind of how I introduced the idea of myopia management and what's happening. So obviously you'll have a quick discussion around your child's nearsighted. Sometimes parents want some proof in that, and you would put the lens on, take it away, and the child will say, yes, it's better. So, you know, that's the first realization that, you know, the child is nearsighted. So you go through those 5 stages of acceptance of bad news. So the first thing that I will try and convey to parents is, what is the expected norm of what's going to happen to my child? So, you know, he's coming at the age of 5 or 6, and we've picked up he's a minus of 50. Most kids will come in around about ages 12 or 15, and at that stage they're probably already a minus 1-ish, because that's how they've picked it up. You know, so you get children at these various stages. And so this is data from our practice, and you can do it if you've got a long-standing practice. Just do a retrospective study of all the children and how they've grown up in your practice. And this is before we've started doing myopia control or management. And you get these data sets starting to develop. Now, in my practice, in our minds, we almost had these 3 tier groups that develop. So I call it my early onset children. So these are the kids who would typically, by the ages of 4, 5, 6, start showing those early signs of myopia. And this is typically when either both parents are myopic, or when parent set is got quite a high prescription. You tend that their kids might start a little bit earlier. And if you look at research, the recommendation is children can increase in myopia roughly a half diopter to a full diopter per year, average about 0.75 at that 12, 13, 14-year-old age, you know, depending on which data set you're looking at. So the child who starts at age 5 or 6, they are typically the high, fast progressors, and they are the kids who's going to hit those -6s, -8s, 10s, and above. So they for me are the most important group to catch early, because for them you can make the biggest impact. And then you have the meat and potatoes group. It's that 12, 13-year-old group where a lot of people tend to go myopic who are going to go myopic. So that would be the main group of kids going myopic. And again, you're looking at that group ending up -4, -5 when they're adults. And then you have these late onset, almost adult onset myopes. And they're the ones who start around about age of 16, 18, just in a school, starting college. And they're the group who end up this -1, -2 grouping. And again, there's going to be different data sets. There's going to be variance to this. But in our practice, this was kind of the 3-tier levels that we picked up. Now, you can just use one graph, and there's some of them out there on the internet to have a look at. The point, and this is how I would introduce myopia management, is if you look at these graphs, the main thing that we know about myopia, it's progressive. It's over time, your child is going to become more myopic. And I think that's the key concept to convey over to parents, is this is not a once-off. You know, it's not just a set of glasses. We give it now and your child's good to go. And, you know, he's fine for life. This is an ongoing progressive, and I won't use the word disease or disorder, but condition that's happening to the eye. And so we can go with traditional routes, which would be your normal spectacles or soft contact lenses. But luckily for us in this modern day and age, we have other tools that we can introduce to your child that we can slow down that curve. Not completely reverse it at this point, but we have tools and there's data supporting it. There's now FDA lenses. You know, parents just want to know the science behind it. So, you know, some parents you'll have to go and show the studies, some just take your word for it. But we do have science supporting that we have these certain tools we can use that will slow down that curve. So the earlier we can start that treatment with your child, the bigger the impact down the line. Because what we know from most myopias, large, big percentage of them, they all tend to stabilize. The progression tends to stabilize in your early to mid-20s. And that's basically when all the growth hormones stop and so forth. So your catch area for myopia management is that onset age up to about your early 20s. That's when myopia management has its main impact. And that's where we should be targeting myopia management. So the earlier in the process of that child that we can catch and put treatments into place, the bigger the impact we have down the line. Now, at this point, the parents might ask, well, what are those tools? Or you can say, well, the tools that has been shown to make the biggest impact, and then we can go over that conversation. And I'll show you the slides according to that. So the other thing is, and sometimes parents need a bit more of reinforcements, and that's where the next slide will come in, Darren. So this is data that was gathered from the Brian Holden Institute, and it's that classic one that you've seen now that shows as a population, as a world population, myopia is on the increase. And you can give those stats that half the world population is going to be nearsighted by the year 2050. The point that this slide brings across to the parents for me is my child's not alone. This is not isolated. My child's part of the bigger planet, and this is a common trend. And this is a great time to start introducing all those other factors like playing outdoors, screen time, you know, visual hygiene. So these are all great points not to bring across. So even if your child's not nearsighted, still be aware of these things. Or if there's a brother or a sister, you know, let's discuss, you know, common ways you as a parent can help your children to be safe from being part of that grouping. But it also tells the parent that if my child is nearsighted, he is part of the bigger pandemic, if you wish, part of the bigger thing that's happening out there. And it just puts everything more into perspective for the parent. And they feel a bit better about their child. There's nothing wrong with their child. It's happening to 50% of children all over the world. And he's just part of those numbers. So this is kind of another slide that I would bring in with parents, and just to give them the bigger picture, make them understand how things are. And this is available on the internet for them to go and look at. So some parents need this just to get a better idea of where their child sits into it. And then if you look at the next slide, Darren. A lot of people asked, and for me, the myopiaprofile.com website is a gem. This is something that was put together by Katie Gifford and her husband. These are a number of tools on that website that you can use. One of the very nice ones is this myopia risk profile that you can sit down with the parents. And it's something that you just, it's a questionnaire essentially, and you will then, circle or highlight it. So, is one of the parents that's myopic, is both parents myopic, that increases your risk. Ethnicity increases your risk. Individual risks, stuff like how much distance work are you doing versus near work, how much time are you indoors versus outdoor. And by just circling all of this, you're creating a risk profile. And again, the parents can see there's science behind this. And it also gives you a risk profile. So, if the child's not nearsighted, but his risk profile is high, here's more evidence that you should be following up that child on a more regular basis, even every 6 months in some cases. There's some other nice tools. There's some pamphlets you can download from that website that you can hand out to parents or discuss with parents as well. So for me, that's quite a handy website to go and visit and see what you can get from there that you can use and hand out towards patients, or at least go through with patients. So I know last week there was a number of questions, where can I get more information? For me, this is probably one of the go-to websites, is the myopiaprofile.com website.
Did you get
Katie,
the previous slide? Is it this slide, Dr. Dassey? Maybe the one before that. Yes.
Is there a question?
Yes. Before this.
Now we're going to have to move along.
Okay.
So we'll come back. We'll get their comments, and we can make this information available.
Cool.
Okay.
All right. So let's move on to the next slide. So that's a good resource. Now, when we start discussing different treatment options, and there are a number of studies out on the website that you can reference to. I grabbed this one. I like the colors, and it's quite clear as to what you're trying to communicate. And this was done by Charms in 2017, published. So I would then go ahead and say, look, we have all these tools. We've talked about the progression. We've talked about what we can do to slow down, or there's the possibility of slowing down that progression. You understand your child is at risk. It's part of the bigger global phenomenon that's happening. There might be some other stuff that you need to discuss. And then obviously the final question is, all right, I'm buying into this. I'm understanding you've made your case. And as a parent, I can see there's science behind this. I can see it's logic. It makes sense what you're trying to explain. How do I go about saving my child's eye? And I mean, there's another slide you can do on all the risk factors of high myopia if you want to scare parents. So if you go back one slide, Darren. So the next step for me is then to say, all right, what are my 3 tools? And at the moment, those 3 tools will be soft contact lens multifocals in all its different modalities. It will be orthokeratology, and it will be eye drops. It will be primarily your atropine, and whatever else will come along in the future. And so what's come out of these studies is, depending on whose study you're looking, some will say Ortho-K is better, some will say atropine's better, some will say soft contact lenses is better. But in essence, this is not a myopia control talk. This is about getting a child into myopia control. And depending on what philosophy you are fitting, what you are comfortable, the tools that's available to you, you will have discussions around these three tools. And so you would then go, in my mind, go through the pros and cons of each of those modalities and what's available and what makes sense for the parents and for the child. So if Ortho-K makes sense, then that's where the Ortho-K discussion now comes in. All right, so after all of this, we've had this brief discussion. Let's talk about Ortho-K and what boxes are Ortho-K ticking for your child. Well, we've talked about myopia management, which is a big factor. Your child is only wearing the lens at home, which means when they're away from the home environment, when they're doing sports, when they're at school, they don't have to worry about wearing a contact lens on the eye. They don't have to worry about wearing spectacles. So especially if it's a sporty child, that sells itself. You can talk about just your child's well-being, emotional well-being, the fact that they don't have to wear glasses, stuff like that. So these are all the type of discussions you can have about Ortho-K. The old sales of, this benefit of my child wearing the lens because they don't have to wear it at work or at home or at school. They only have to wear it at night while they sleep. They can go and swim and do all the things a normal child does. There's work done by Katie Gifford around the binocular vision that sometimes improves in certain conditions by doing Ortho-K. So you can do the BV route, and then obviously for me the myopia control is a big factor. And if you look at myopia control meta studies, the one that's been studied the most and gives the wider, bigger, longer term picture is Ortho-K. So there's no reason not to consider Ortho-K for myopia management, and there's obviously different criteria to follow. But that for me would be a basic guideline that I will go through with parents to build them up to the discussion of, let's do Ortho-K with your child. So it does take a bit more time. You've educated the patient, and the patient might walk away, the parent might walk away and say, no, I don't buy this. It's great. Just give them a pair of specs. That's fine. That's the parent's decision. And you'll get cases like that. But this information is imprinted in the back of their brain, especially that one where you see that progression happening. So 6 months, a year down the line, that parent's bringing the child back and his scripts increased by 0.075 diopters or a full diopter. Now I find parents will come to you and say, remember that discussion we had last year about those things we could do, to slow my child's eye going bad thing, that thing? Can we talk about that again? And so that creates that second opportunity on the follow-up to reintroduce stuff like Ortho-K or some of the other myopia management stuff. So this is my approach. This is something that I would do in the practice when we talk about children being myopic and how I would introduce, for instance, Ortho-K or myopia management as a process. Any other comments, Darren?
No, I think you summed it up well. The one thing I would mention is that myopiaprofile.com is a great site and a great resource because they don't focus just on one modality. They discuss in their studies show all three of the combinations or all three of the different options.
And I see quickly on the comments section is, should we use cycloplegic refraction? There's definitely a place for dry and wet refractions, and you want to make sure you catch all the myopia. So is it necessary for young children? Absolutely. For older children, you can probably get away just doing a normal HEC type test. But you want to make sure you catch all the myopia, but you also don't want to overcorrect your child. So as long as you're confident you're not going to do over minusing, you should be fine. Over minusing, if you do it, you will pick it up down the line in your refraction over lens and with your residual refraction. And then obviously more and more attention is being given to your binocular vision as well. So we need to be aware of the binocular state of the child, because we know that a lot of nearsighted kids tend to be more esophoric as well. So there's that component. And if you want more information regarding that, the Myopia Profile website has heaps of information regarding the binocular vision aspect and how to look at that for myopia management. Any other questions? I see there's a question regarding the source of the previous slide. I would assume that would be the one that shows that progression. So that would be the first one in that grouping, Darren. That slide is a personal slide, so it's not a formal study. That's just the one prior to that, Darren. This is from the Brian Holden Institute, that one. There is some similar slides on the internet in research that you can pick up. This is just something that we did in-house in our own practice. And if you have a long-standing practice, just grab a bunch of kids that you've seen or that's been seen in the practice over the last 20 odd years, and just go and plot their prescriptions on each visit, and you'll start seeing similar type of graphs developing. You don't need to use exactly this one, but you want to use any form of graph that shows a progressional state. And there's a nice one on the internet that shows, it's a US-based study of the increase of nearsightedness over age. It doesn't break it down to his brackets, it's just the overall increase. And you definitely see this massive increase in the incidence of myopia around about that 12, 13, 14-year-old grouping. So we know that's where the majority of kids will tend to become nearsighted. There's some slides, I think, from the Brian Holden Institute that shows the impact of intervening with a 50% reduction in myopia control and how it improves the risk factor of developing myopia or high myopia onset pathology. And if I remember, there was a 10 times decrease in risk by doing a 50% reduction in increase in myopia. There was a 10 times decreased risk of developing pathology in the eye, in a sense of losing vision at a later stage in life. So you can use any of those graphs. All you want to convey with the parent set is that as the child gets older, that they're going to become more nearsighted. That's all you want to convey with this slide. Any other questions then?
I think, Charles, you did a great job. Go ahead, Angela.
Oh, I just said I didn't see any on here, but please, if we're not just accepting questions, if anybody would like to provide any of their tips or techniques or suggestions to other practitioners, please do so. This is a great opportunity.
I'd like to take this opportunity to thank Charles. He has another obligation and is going to be taking off here shortly. Unfortunately, a lot of the practitioners are heading back to work in the upcoming days and weeks. And so we've had requests to continue the conversation, but to move it to a later time of day. So stay tuned. We'll be announcing the new time for these continued up. I guess we're going to have to change the name from lockdown lecture to not lockdown anymore.
Just lecture grouping. Yeah, so I mean, there's lots more to discuss, and we're happy to continue this trend if there's any more questions. I know some of the things, Darren, that we want to look at is maybe giving some of the practitioners a chance to do some case studies on some of the EyeSpace lenses they've done, and I think that can generate a lot of interest and talk as well. So from my side, I just want to thank everybody for being so faithful and listening. It's always nice to see that people are interested in what you say. And I hope that this discussion we've had today gives you a broader sense of how to manage and how to talk to parents. I think that the key important fact here is education. For me, it's that relationship you build with either your patients if they're older, and or the parent set if it's a younger child when it comes to Ortho-K. For me, it's a synergy between the patient and you as a practitioner, and there should be a relationship there. Ortho-K for me is something that needs to be earned, if you wish, from the patient's side. It is an elective process. but it does generate a different relationship between yourself and somebody that you would just, give a set of glasses to. And it's not uncommon for Ortho-K patients who's been with you for a long time to become almost like friends. And again, they are one of your more loyal customer base, and people will travel to come and see you if you do Ortho-K successfully with them. So if you're not doing Ortho-K, I do want to encourage you. It's one of the most fulfilling aspects of optometry in my mind, and it definitely brightens the day when an Ortho-K patient comes into the practice. So with that, I'm going to sign off, and I just want to thank you for your time.
Thank you again, Charles.
Okay, bye-bye.